Greetings and welcome to the edition of HFS Unfiltered videocast. My name is Rohan Kulkarni and I lead the healthcare and life sciences practice here at HFS Research. And I have with me Dave Kerrigan today, who is the CEO of Benefit Pitch, a searchable database tool that allows benefit professionals to have access to key information on innovative companies offering services to self-funded employers. He's also the founder and managing director at Sante Nask, a healthcare and employee benefits advisory consulting firm. Welcome, Dave. Thank you for spending time with me this afternoon.
Rohan, it's a pleasure to be here. Thanks for having me.
Absolutely, my pleasure. So on deck today is for Dave and I to talk about the changing dynamics in the healthcare market, particularly self-insured employers who are employers who essentially underwrite their employees' medical risk versus buying health insurance from carriers, who have now become the largest market segment, accounting for almost 25% of all enrolled beneficiaries in the US. So, it made sense for employers that were flush with cash post-2008 financial crisis to begin underwriting the medical risk of their employees versus, paying premiums to health insurers. This was supposed to make their healthcare costs a whole lot predictable, reduce the rate of increase in cost, and even get better control over their employees' health benefits. It does not appear to be the case, as most of all the self-insured employers have abdicated that role and have essentially gone back to health insurers to deliver services in terms of administrative services, for instance. Now, personally, I find this quite mind-boggling for employers to take this approach where they are taking on the risk by underwriting their employees' medical risks and have no control over the outcomes. So Dave, I'm curious, give me your perspective about what the heck is going on.
That's a loaded question with a lot of potential responses, but I'll do my best here. There's a couple things to keep in mind. The concept of self-funding does not necessarily mean that the organization has control over the costs. It means they've become a risk-bearing entity that generally allows them to pay less each month in premium, avoid certain fees and taxes, so to speak, because they're self-funded, avoid certain mandates, frankly, which can be costly, and have more control and decision-making over what is covered and what isn't. Because when you're a self-funded employer, you can choose riders that cover more cycles of IVF or not cover it at all, cover bariatric surgery or not at all, cover transgendered services or not at all. And all of those things, as you know, if there are folks incurring those costs, will be a cost to the employer that they will then have to pay. Or if they don't want to cover it, maybe not as desirable an employer to work for, but they do not have that risk of that cost because it is not a covered benefit. Where the rub lies is that many of them are using the third-party administrators, TPAs, that belong to or are owned, and health insurance has over time, created these networks. These networks have negotiated pricing between the payer, the insurance company, and the provider. And over time, those costs have unnaturally inflated. So much so that you could have a situation where, as a direct pay person, I could go to a hospital and say, how much to have an appendix removed? Standard procedure. Mm-hmm. And not that they would ever give you the cost directly, because it's really hard to do, but it could be a certain dollar amount. If I were to put it through my insurer, depending on their contract with that hospital or provider, could be higher. You never know. That transparency or lack thereof is a problem. The inflated prices that occur when the insurer and the hospital system or provider are negotiating those prices, that is the issue that is at hand here. Because even if an employer is self-funded and they're using a third-party administrator that is owned by a health insurance company, they're relying on the contracts that they have with those providers. And if they're inflated, if they are not cost-effective, the employer does not see any benefit on a cost control standpoint in that respect. Where they might see it is if they bring in third-party entities for navigation and cost containment and things like that, medical management programs that are outsourced versus the ones that are done by the carrier. They may see some savings there, but the underlying charges that occur when they go in and consume care, or their individual employees consume care, is driven by those contracts.
That's a very fair point, Dave. But let me ask you this, right? In not only do you make a fair point, and I think to be fair to some self-insured employers, I think they have taken on some of this on their own by having these direct to provider contracts that potentially will address both the cost of care as well as the quality of care, depending on the type of therapy, for instance. And most of these contracts, as I understand, are becoming value-based or outcome-based contracts.
Yeah, reference-based contract, value-based.
Correct. And now my general sense is that's still very nascent, and it's not at scale by any means. So my question to you is, you talk to employers all the time. Do you think that they might scale this, that this might be the way that they're going to approach this in the future, where they go direct to the providers and kind of cut out the health insurers? Because in so many ways, the provider networks are becoming more of a commodity product at this point in time.
I suppose two clarifying statements before I answer that. One is I'm no longer a licensed broker consultant, so no direct access to employers. And even through my consulting work, I generally don't work with employers directly. I work with a lot of vendors and solutions, and I work with a lot of benefit brokers and consultants. So with those disclaimers in place, I would say that each year gets more interesting in that employers working with benefit advisors, and I'm using advisors a little differently. There are brokers, consultants, advisors. Advisors are generally a little bit of a different designation in that they can charge fees versus receiving commission. So I don't want to go too far down this rabbit hole, but it's very important to know as a purchaser of healthcare that the brokers and consultants that do work with carriers are reimbursed either a percentage of premium in a fully insured scenario, or oftentimes a fee related to headcounts, number of employees, PEPM, PMPM, those types of things. Not every case, I'm making some generalities here. But in those scenarios, there is a question of, who serves whom, right? If there is an insurance increase, does that benefit the broker? Yes, it does. Are those fees disclosed? They should be. In a scenario where you've got a licensed advisor who can charge fees and they're getting out from under a traditional relationship that a broker has with an insurance carrier, that's when you see them getting more creative about the solutions and realize, hey, it might not make sense to work with a health plan directly for this employer, or to use that health plan's TPA, but rather use an independent TPA, not tied to a particular insurance company. And to the point you made, they're realizing that if they were to go directly to a hospital system and say, this employer in your backyard has this many employees, I'd like to negotiate that anytime let's just say that it's a hospital that is very strong with musculoskeletal injuries and services of that respect. Anytime there is a hip replacement, knee replacements, anything at all related to musculoskeletal, that hospital will be either the preferred facility or the narrow network facility, whereas they can't get the care anywhere else.
Yeah.
And because of that volume, we're going to direct to you, Mr. or Mrs. Hospital. Here is what we'd like to negotiate for a fee. And there's many ways to do this, not to get into that detail, but it can be a percentage of Medicare plus a percentage. It can be reference-based pricing, which is a little bit easier, I think, and that's related to what I just stated. Value-based is a whole different story. Won't get too deep into that, nor am I an expert. But those scenarios are very interesting and intriguing because the employer working through that licensed insurance advisor on this sort of direct contracting with a provider system does frankly eliminate a middle layer of administrative fees. And as I already mentioned, somewhat inflated fees. And to create a network that, as you already said, has become a bit commoditized. In my area up in the Northeast, my doctor is likely in every major insurance company's network, and therefore it's not so much a draw to say we have your doctor in network. This does not come without its challenges, so I don't want to continue too far. I'll pause there, but I'm encouraged by what I'm seeing. There's two major pieces that need to occur here, both of which are not minor. One is you're talking about the broker consultants moving into that more advisor capacity, where they're moving out from under an insurance commission payments relationship, and they're finding the right fit sort of clients who are willing to take a risk, frankly. It is not a usual scenario to offer a direct contract pricing arrangement with a provider system, hospital system, or a bunch of hospital systems for an employer population. It only happens when certain things, are in place. And I usually say that it's when the pain of change becomes less than the pain of staying the same. That when that pain becomes, staying the same becomes too much, that's when they're willing to take the risk to move to a different broker consultant, to venture down that path of a direct contract, knowing that it might be a narrower network, different experience for their employees.
Very nice. I think you framed that really nice. But just for clarity, an advisor would essentially be a fiduciary, I would imagine. Would that be?
Yeah, I don't want to get into the details. I never was a licensed insurance advisor, but generally speaking, my understanding is the responsibility under ERISA laws and things as it is today becomes a little cleaner when it is that more direct relationship between the employer and the licensed insurance advisor, especially in those direct contracting scenarios. Because considering, again, no expert in ERISA law here, but considering who should be served under those relationships, but then where the money goes, some could argue there are, fiduciary conflicts left, right, and center under current models. Let's say current, the models that are the premier models in the market today. Understood.
So let me pull you in a little bit of a different direction because this to me is a little baffling to some extent. The data is telling in that the population covered by the self-insured employers is now the largest segment, like I indicated earlier. About 25% of all Americans are part of some self-insured enrollment at this point. And if I were to quantify that for people who don't fully appreciate the size of the market, we're talking about a spending power of at least $500 billion, at least. And I would imagine that should give employers a lot of leverage, but I don't see that happening at this point in time. And I'm just curious, why do you think that despite this kind of a spending power, employers don't have much leverage? And you kind of began to address that in the previous question where, we're talking about the pain of change and so on. Maybe there's some element to that or not, but I'd love to get your thoughts around it.
Yeah, it's an interesting question in that, in theory, what you're saying makes a ton of sense, right? If the majority of the market purchases in a self-funded arrangement, shouldn't there be more controls or ability to call it influence the market, change the market? And the answer in theory is yes. I'd say that there are some components that maybe need to be understood a little bit more. One is that if you consider, call it, lobbying or purchasing organizations, when there are those entities on Capitol Hill and other places, and there's influencers at a policy level that can help sway things in your favor, I think that makes a difference. There are organizations and coalitions of employers that have large employers working with them, and they are working to effectuate change in that respect. And there are many that are doing some really interesting things around some of the things we've already discussed: direct contracts, value-based care, et cetera. I'd say that despite the fact that the majority, as you're pointing out, are still buyers, there are many, many reasons why insurers become self-funded. And there's a spectrum, I would say, of self-funding. There's an entry-level point, which is when you realize there are some costs. The cost-benefit analysis works for you. As soon as you move to that relationship, there is a reduction in spend right off the bat because you're getting out from certain pricing and insurance costs in a fully insured scenario. That might be enough from an employer standpoint to say, we're good. We've saved some money. We're happy here. It does not mean that they are at the other end of that spectrum where they realize their ability to effectuate change and take control of this market. And I say take control, that's a bit of an aggressive term. To your point, though, this is the most, each year gets more, but each year is more than the last year, in that the number of brokers, consultants I hear talking about this, the number of employers I hear talking about this. I see it at conferences as a discussion point. You're seeing that needle being moved ever so gently. I don't know that there is an imminent tipping point. I would not say that there is, Because keep in mind a couple things. Employers offer health insurance and benefits in general to their population for generally two reasons. One is it is a way to attract and retain talent. And the other is that when you are in a self-funded arrangement, the ability to control costs and drive better decision-making via the different programs and vendors and solutions that are out there allows you to control your spend a little bit more. So it's attraction, retention, and controlling of costs. Some of the things that we've talked about are really on the far end of, call it the aggressive nature of what an employer can do. It can affect attraction and retention in a negative way. If I'm looking for a robust network because I've got a child with special needs or a wife who's undergoing a certain kind of care, or myself has a certain illness or condition, I don't know that I want to go work at an employer who has these great direct contracts and lower pricing, if it means I can't see a doctor that I want to because I've done my research and the best person for me is at this hospital, and sorry, they're not in network, there is no direct contract. That is a very key component to what an employer, why an employer is attractive to an employee. And frankly, the vast majority of folks aren't there yet. And there's a question of whether or not they'll get there, because I can tell you, I've heard and read some information and articles on when women should get mammograms. And, maybe an employer that's in a direct contract can say, we allow a screening every 2 years instead of 1. That's a risk, because if you're talking to someone who's got a history of breast cancer in their family, they're not going to be too pleased that they can't get their annual screening. So, that produces an instance where someone might not want to work for you in that case. And employers are very cognizant of what they offer as benefits from an attraction retention standpoint, especially in this economy, because as you are well aware, this kind of, I'll say post-COVID, I don't know if that's the correct term, but as this pandemic appears to be winding down, talent is scarce and hard to come by. And the great resignation means that folks are looking for greener pastures, and an employer's ability to want to really shake things up right now, probably less than it was a year ago, but still this train continues to move ever so slowly down those tracks.
Fair enough. Let me make just one point before I ask you my next question. I tend to agree with everything you said, but I also believe that where we are, I think we're getting to this point of reckoning, as in employers still in the 21st century, 20 years into the 21st century, still have a very, very legacy mindset in terms of health and healthcare. I would imagine that employers ought to start thinking about it more in terms of productivity versus healthcare. Ought to be trying to leverage social determinants of health in order to try to influence better behaviors, right? And if that were to be the case, it's going to require a paradigm shift. And I just don't think that we have sufficiently enough progressive employers there. It's a little bit harsh, I recognize, but still, let me get into my next question as well, because it's kind of where I'm trying to pick your brains on, is the fact that I've had a few conversations with benefit leaders at multiple self-insured employers. Mm-hmm. And primarily, my interest in having these conversations was to explore possibilities around new health and care paradigms, because I'm pretty much convinced that what we have today is not working. And it's not working because we're getting sicker in terms of comorbidities. For instance, 30 to 40% of Americans have one or more of hypertension or obesity or diabetes. And our life expectancy is actually declined by one full calendar year. That is pre-COVID, between 2010 and 2019, right? So outcomes are not really good. And what I recognize, what I took away from the benefit leaders at these self-insured companies was they are driven by a certain intrinsic fear of change. One. Two is they're unable to envision what an alternate model would look like. And there is a third risk, which is about trying to disrupt employees. Because to your point, employees also have gotten used to a certain model. And most seem to be reasonably comfortable with that model, even though there's a lot of opportunities for improvement. They seem to be fairly comfortable there. So I understand the rationale. But what I refuse to buy in is that why do we continue to pursue what is not working? Right?
Great question. You made a statement in there that that was interesting, and I'd say gently correct it, or at least clarify it. So when
Sure.
you say an intrinsic fear, the jobs that they're in, and you can say this is your financial leader for a company, which might not be as much, but let's put them over here for a minute. But an HR person has a certain job and a certain outlook, and I'm making some generalities here.
Sure.
But they are a cost center, not a revenue center. Their job is attraction, retention, happy employees. Much of what we've talked about is change, is disruptive. And you can say it's an intrinsic fear. I'd say that's not what they're hired to do. If it were easy, everyone would do it. Starting your own company, I know this. I've got 2 companies I run, not easy. If it were, maybe everyone would do it.
Sure.
Are there rewards there? Are there benefits? Of course, but they're not without some major risks. These organizations are not incented in any way to be rewarded for doing these things other than financial. And I'm making a bit of a generalization. Yes, there are longer term benefits of better care, to your point, moving from health care or sick care, as they say, to actual health and wellness, which is a reward or focus on models that reward or drive a particular focus on keeping people well, keeping people in a disease state from getting worse, and managing illness and acute events when they occur. Not how the system was built currently, and to your point, kind of broken and not exactly working. And yet back to the pain of change versus the pain of staying the same. The dollar amounts that are saved when an employer changes dramatically, is it worth the fundamental disruption that occurs, the loss of employees who don't like it, have to hire and retrain and all those other things? I don't know the answer. Fundamentally, it would appear the answer is no, at least not now, because otherwise we would have seen the shift, the paradigm shift. That said, I'm really intrigued to see what the coming years bring for a number of reasons. One is, I think, call it a Capitol Hill outlook, you're seeing more a push, bipartisan push on transparency in the pharmacy side, transparency on the provider side. So that is not being relinquished. Surprise billing, supported by both parties. So you've got that. Couple that with a workforce that, I'll say this, the current decision makers in many employers, are baby boomers. They're moving into retirement. They are going to hand the torch to another generation. The next generation, isn't, there's baby boomers, there's Gen X, there's Gen Y, millennials, Gen Z, right? And I'm, again, generalizations. The largest volume of active participants after baby boomers are millennials. If you haven't realized how a millennial approaches life in general, I'll say, it's different. Their perspective, what they want, how they want it, when they want it, how they want it delivered, much different than traditional. And so with a couple of these other shifts in place, political shifts, brokers and turning into advisors and working differently, decision makers coming into a market and going, I can't stand my current care because it's not care, it's sick care, it's this, let's do something different. I think we are more primed now than we ever have been to solve the very question that you asked, which is, the vast majority of folks are self-funded. There's an opportunity to really take advantage of this. Why hasn't it happened? I'm saying stick with it a little bit longer.
Encouraging. And look, I think that generational divide that we are experiencing, I think has a lot to do with it, because a lot of the folks that I spoke to were definitely of a different generation where they were fairly comfortable with the status quo. I think to your point, as the millennials come in and they begin to consume more and more, because the oldest millennials are already in that bracket where they're beginning to consume healthcare, right? So they're certainly going to get rather emotional, if not outright upset at the status quo, and I'm certain they will make some changes there.
And they're at the age where they're starting to take on more leadership positions in the companies in which they work.
Absolutely, yeah, indeed. I mean, look, I don't have the data right in front of me, but the median age of digital health company leadership are generally in the millennial generation. So to your point, not only are they taking leadership roles in self-insured employer categories, but they're also taking leadership roles in sort of the, what I would say, the disruptive part of the healthcare ecosystem. Talking about digital health companies, let me ask you this. There are some new companies out there, and I'll call out Transcarent in particular, being set up that are attracting a lot of funding, suggesting that the market thinks that the self-insured space is really ripe for some action. So I'm kind of, let me pick your brains again to your earlier point there. You're talking to folks out in the marketplace, providing some guidance in understanding that. So help me distill this marketplace and talk to us as to what are those kind of dynamics that you are seeing at play.
Well, to your point, the number of investments in the digital health space, insurtech space, HR tech space, and those spaces have some overlap. But over the last 2 to 3 years, there's been $1 billion a year, at least in each of those categories. I think HR tech's, solutions spun it into $1 billion in 2018, 2019. The rest had already been investing $1 billion or more each of these years. And you can find these resources in a couple of different places. There's pros and cons to this, in my opinion. And I work in this space. I've got a marketplace with benefit pitch of more than 700 vendors that offer services in these categories. I love this space. It's a passion of mine. I'm encouraged. I like working with the companies themselves as a mentor advisor for different accelerator programs that I'm involved in as a mentor, pitch stage, judge, coach, et cetera. I love this stuff. The change, I think, comes from new players to an extent versus existing. But at the same time, we're all caught up in the paradigm of a system that fundamentally, I don't know how to fix this, but if you consider this, the current problem, and I'm making some really big generalities here. Current problem, health insurers, and not all are publicly traded, but let's just pick on them for a minute. They have a board, they've got targets and financials they need to hit. It is not in their best interest to disrupt and change, right? They've got to keep people happy. And yet, if they don't, they risk being disrupted. And I'll use a quick example. I think I might have used this when we had a discussion a while back. Ford and Chrysler, GM, before the energy crisis hit, some folks probably looked on the horizon and said, hey, look, there's some things changing in the marketplace. Maybe we should consider a move to hybrid or hybrid electric or all electric vehicles. And at the time, Chevy Tahoes and Ford Explorers were all the rave, and they were the majority of sales, and they were not slowing down at all. Demand was as high as it's ever been. And folks looked at them and said, you're crazy. And yet a couple of years later, there's an energy crisis and there's bailouts from the government to these very motor companies that manufacturing these really big gas guzzling companies, cars. Not a dissimilar situation in that you have these big insurers and hospital systems and employers, frankly, all of them are part of this in many ways. The disruption may come from the startups in that new community of VC-backed organizations. But keep in mind, VC-backed companies also have a goal of getting to at least a break even, get in the black, returns for their investors,
Sure.
Further Series A, B, Cs, buyout, going public, IPO, and the process kind of repeats itself. They get themselves into the very mold of the entity in which they were potentially disrupting, right? So at what point does an organization that, and I'll use Medicaid as an example, and to the social determinants of health side, only in the past couple of years do you see VC firms saying, I'm going to get involved in companies focused on social determinants of health and Medicaid. Largely not a particularly lucrative or the returns are questionable, I guess is what I'd say. And I'm no expert here, I'm not an investor. And yet, the number of companies that are VCs that are starting to focus on this because they realize it's the right thing to do, it's kind of encouraging. Investing in mental health was never a thing because mental health reimbursements are generally one of the lowest in the space.
Right.
Hospitals always tout the new women's health center or cancer care center. Those are revenue generating centers for a hospital. Returns on behavioral health centers, not so much. So those intrinsic changes have come from startups, have come from VC-backed companies. But how do you fix the problem of their goal is to grow, get acquired, acquire, go public, and then they're part of the same machine that rewards shareholders and stakeholders instead of, or maybe the priority should be on the patient, the consumer, their customer. Sometimes the scale weighs heavily to the other side of the investors and the shareholders, and lather, rinse, repeat, you're right back into the same cycle.
Yep.
So I'm interested to see what happens with the many digital health companies that are getting funding now, and they're targeting this space to disrupt and change it fundamentally, getting into well care, not sick care. When they're made an offer from a major insurer, do they turn it away, or do they take it? And don't know the answer. And frankly, there's going to be a lot of variation in those responses depending on many different factors: who the company is, their founders, et cetera.
Absolutely. Yeah, and I think there's a cadre of digital health companies who are certainly taking disruption to heart. There's one called Forward Health, for instance. One of the things that they clearly state in their FAQs is that they do not accept health insurance because they think health insurers are at the core of the problem in terms of healthcare delivery. So there are some who have gone to the extreme edge, if you would, in terms of trying to push disruption. To your point, we shall see where this will go.
Yeah.
Dave, we just have a few more minutes. So let me ask you one final question in terms of looking into the future. I believe that climate change is the ultimate existential crisis facing us. I think it's probably 1000x times of the pandemic that we're just recovering from in terms of ferocity, if you would. I believe our benefits construct, particularly in healthcare, have inculcated certain bad behaviors in our lifestyle choices that are contributing in major ways. As an example, I think we prefer to drive versus walk, or even take public transportation. We tend to choose meat over fresh produce. We tend to choose sugary drinks over water, for instance, all of which are unnecessarily adding to the carbon footprint. So I'm just curious, from your standpoint, again, not specific to healthcare, but just as concerned citizens of the planet, and we clearly need to redefine our benefits to incorporate sustainability into it. I'm just curious, what are your kind of final thoughts?
As a person who's got a healthcare focus and not necessarily climate change, I think that there are pieces that overlap more so than one might consider. So you mentioned a number of different things. A little while back, I'd done a little reading on, kind of the history of how cities were developed and how certain industries grew. And so, two examples I'll give. When a city like Boston, I'm from the Boston area, when it was inhabited in the early days of this country. It's a very walkable city. So if you are in the city of Boston, you don't necessarily have to take a train anywhere or trolley or cab or an Uber. You can walk most of it. As cities have developed over time, they've become more sprawling. And then there's a question of the infrastructure that allows a system of transport sponsored by that city. And then as the cost of living goes up, folks move further out. And then there's a question of, okay, well then how are they going to get into work? Assuming a traditional workplace, they're going to drive. It's more convenient. So every family has 2 cars. Oftentimes they're gas guzzlers. A little happier that there's more electric options and hybrid options. But what does a hybrid workplace do with this? I can tell you that we had a situation where my wife was in a minor car accident. Car was considered totaled. We have not replaced the car because we can do just fine with one, at least for now. Encouraging from a future carbon footprint standpoint, potentially. Related, the other point I was going to make is when you looked at to bolster the farming industry years back, there was a premium put on growing corn and what corn could be used for, and ultimately corn syrup that is put into, as you may pointed out, sugary drinks and other things. It is low cost. It is easy to manufacture and create food and drink that has corn syrup at a low price. The challenge that I see as it relates to the healthcare side of things is you then have people consuming sugary drinks and things because their dollar, which might be limited, might be budgeted, might be welfare dollars, Medicaid dollars. You can do more with those types of food and drink than you can with organic, wholesome, to your point, fish, not meat, and other things, less sugary, more water, or more healthy. Those cost more. And so, couple that with where they live, the water they drink, the air they breathe, that starts to get into your carbon footprint standpoint. Where are they living? Well, they don't probably have much of a choice. So if it's low income housing, it's near highways, the air they're breathing because there's cars that are driving and the gases they're emitting. This world of ours, we only got the one. And I think that, to your point, though different, the carbon footprint and the health of a society, they're not too dissimilar in how we've currently looked at them.
Yep.
And how we should be looking at them on a go-forward basis.
Absolutely. Absolutely. Very good. Dave, thanks so much. Really appreciate the time. Those insights were, I will tell you from my standpoint, excellent, because you gave me a perspective that is very different from what I'm exposed to. So I really appreciate that, as well as your time this afternoon. So thank you.
It was my pleasure. Thanks for having me on, Rohan.